School Board. What will be your first?
I saw your campaign thing today.
You laugh, but that's not a very comfortable chair.
Let Matt sit there. He wants to sit back there.
No, I'm good.
I didn't hear the word he said.
You ready, Mr. Bass?
All right, bear with me. This is my first time. So we're calling to order the Insurance Committee meeting. All present, we have me, Ms. Brotherton,
Yep.
Mr. Bullard, Mr. Cheatham, Mr. Dean, Mr. Bamberg, Ms. Smith, Mr. Bachhaus, and Mr. Downey. So first item on the agenda for today is discussion/action of health insurance renewal presented by Jason Allman, Allman Group Incorporated, and/or Nisha Bamberg, Chief Financial Officer. Mr. Allman?
Mr. Bamberg is on the Zoom call.
Ms. Bamberg.
Good evening. I passed out a packet, or we had put a packet in front of y'all. It looks like this, and then there's a separate staple page that's an addendum. Unfortunately, after I had the copies made and everything put together, somebody sent me a revision on something that I had to put in. It was on a fee that Blue Cross would charge if we selected a non-preferred reinsurance carrier. So they reduced it 50 cents. So I put it all in the information on the outside of the handout, which is a spreadsheet. The packet looks big. We're not going to go through it all very detailed, but you need to know where we are claims-wise to understand why the request for this meeting was now and why we have an opportunity to secure stop loss without any further underwriting. If we go past the 19th, we still have the opportunity to secure stop loss, but it's going to be re-underwritten based on the updated claims information. And I'm going to highlight some of the issues we've got ongoing that could change the terms. Okay, I'm not going to get into too much specifics just because of it being an open meeting. The first, as usual, I put together the claims analysis, and I just put in 2 years to try to keep the information down. On the group combined, right now we're 5.6% over cost from last year, cost per employee per month. 5.64, I believe, 65. It's mainly driven by, and we can look at it individually on active members. Active members this year have had a lot of larger claims. Last year, this time of the year, we had 6 people get over $175,000 worth of claims. This year, we've got through May 17. Okay, it's a difference about $3 million on those participants. So when we look at it and it's 5.6 higher, that takes into effect all the medical claims, all the reinsurance we've gotten back, prescription drug rebates, all of that's netted out of it to look at it and see on 5.6. It was 9.5 or 9.6 through April. May's claims were less, probably a lot attributed to COVID and the fact medical procedures were delayed. Some of that may come back, okay, in the months leading up to the renewal. Right now we're at 5.6 based on the claims experience through May. Dental costs are down 15%. That again is mainly attributed to the fact that dental offices were closed from early March through the end of April. So people couldn't get things done unless it was an emergency. So some of that will be recaptured in later months as appointments start to be filled. You can look at 18 and where we were. Through this point of the year, we're only 1.64% over last year. So right now, we're actually about 7% over where we were in 17. You can see where we were cost per employee per month, where we were on the dental, and so forth. That's on the group as a combined whole. If we look at the active employees, which is the section behind this, okay, you can see that medical claims are up 15%. So when you look at that, that's approximately the $3 million I discussed that were on the large claimants. It was all mainly inpatient was the driving force of it. But prescription drugs were also up 7%. They've got the 17 and 18 behind that. Retirees without Medicare actually stayed flat, no increase in the cost per employee, and this is just claims. This doesn't take into effect any rebates or any reinsurance, but just on medical claims, we're flat where we were last year, a 0% increase. A little bit of a reduction in the medical claims costs, a little bit of an increase in prescription drugs.
Mr. Bullard, you have a question?
Thank you, Mr. Chairman. Mr. Alderman, what do you attribute this significant increase in per employee on our active employees, per employee cost?
Like I said, mainly the large claims.
Is it going to be maternity? Is it?
Mainly cancer, bone marrow transplants.
Okay, then the large group, or the group of very large claims that.
Like I said, last year through this point, we had 6 people over 175,000. So far through May, we have 17 people over 175,000.
Okay.
And that's a difference of $3.4 million.
Has COVID, and I know you have some numbers on COVID, I hope you will review those,
Yeah.
but has that had a major impact?
Not on the plan to date. I think there's 27 people that have tested positive. I think there's a total of $21,000 that's been paid out of the fund towards COVID treatment so far this year. So very nominal as far as treatment for Bossier Parish employees and their dependents. Okay. Retirees with Medicare, again, it's actually a reduction. So the weight of the claims cost increase is really felt based on the active employees this year. And that's kind of odd in the fact that most of the time we look at it, it's kind of an even split between actives and retirees as far as where they fall out. So this year we just had a bunch of big claims early in the year. Now one of them was a gentleman that passed away last year, okay, last February. Claims came in when we did the renewal last year. They had $800,000 paid on him. The reinsurer looked at it. We all felt all the claims were gone, done. I called Blue Cross in August to verify if the claims were gone or not. They said, we don't have anything in-house, we're all done. November, a $738,000 claim came on that gentleman from MD Anderson's. So the new reinsurer, I had to read back through the contracts, make sure we didn't have any exclusions, any limitations pertaining to him because he had already passed away, and they paid the claim without a question. So that was a very good deal as far as how it fell out, even though it was delayed in filing by the hospital. Sometimes, and in fact, one of these quotes you'll see that they have a 12/12 limit on that person, which means it has to be incurred in the new contract year for it to be covered. Now that person's been dead now for 15 months. We don't feel like anything else is going to come in on it. But they can limit contracts when we go into them. And luckily, everybody felt like it was a dead issue when, excuse me, bad term, a final issue when we met during the renewal last year. But it wound up, his claim wound up being over $1.5 million. COBRA participants, there's only 6 COBRA participants, and that number varies widely from year to year. I mean, there was a period of time where we had 4 people covered, and it was over $1 million worth of COBRA coverage because one person was very sick. It's up this year 22%, but that's because it was very low last year. And it just fluctuates based on a surgery or anything that's planned. Generally, nobody continues on COBRA unless they have a medical issue. Otherwise, they can find coverage either from the job they're going to, they can buy it on the marketplace many times cheaper than what we can sell it to them as COBRA. So that's the reason for the number being so low. The section behind that goes into the COVID information, and this is a report directly from Blue Cross, and that's why it's sideways, excuse me. But it's in the report itself. And you can see up top it says Blue Cross Blue Shield Louisiana cases, there's 27. This is a report specific to Bossier Parish. It gives you the varying a number based on age of the 27 people that have tested positive and what their risk factors are. On the next page, it shows you that there's 21,145 pricing line allowed amount, and that's what the plan will pay.
Mr. Almond, on this 27, do you have any indication, are these regular employees? Are they dependents? Are they retirees?
I would guess by the ages, some of them are retirees and dependents, just because some are 2 are less than 18, 5 are higher than 75. But I don't know specifically which division they fall in. I can see if we can get that information drilled down if you'd like it.
I would think that would be important as we are moving toward final planning for reopening schools.
Okay.
Do we have a jump in employees? That, I mean, there's no reason for them to disclose that to us, I guess, but at least we would know.
And they'll update this report as requested. I'll update it. I asked for the update this morning. So this is as of yesterday, or as of Friday.
Yes, sir.
I didn't put details down on large claimants, but this is the information on large claimants. Again, we have September of 18 through May of 19, there was 6 claimants over $175,000 of claims paid, representing $2.1 million worth of total claims. September 19 through May of 20, there's 17 claimants over 175, and that represents $5.4 million. So we're $3.3 million on just these 11 additional people. And that's where the big swing is in the active employees. I went through it, and there was only one person that was a retiree with Medicare that was on that list, and one retiree without Medicare. Stuff that's ongoing, there's a premature baby born at 26 weeks that's in NICU today. It's been in NICU since April 21st. If a baby gets full term, it'll be the end of mid-July before that claim is up to be paid. We can push as much as we want, and we might not get it in before the end of the plan year. One of the reinsurance carriers looked at it and put a laser on that person at $1 million. There are 2 people waiting on a transplant, 1 liver transplant, 1 liver kidney transplant.
A little more in depth into that laser so everybody understands. I've had trouble wrapping my mind around it, so can you help me out?
So today, everybody on the plan has a $350,000 specific deductible. So what that means is Bossier Parish School Board is responsible for the first $350,000 of payable claims. Blue Cross administers it, but y'all are self-funding up to that number, and the reinsurer picks up. There's only one participant today that has a higher deductible than that, and that is a laser. And that laser is on a gentleman that's taken $44,000 a month worth of prescription drugs for a treatment of a pituitary disease that keeps his cortisol and different things in a level. Unfortunately, it's one drug, and it's an orphan medicine for a rare disease, and there's no getting around the price of the drug. We've tried every other way to do it. But a laser gets a higher deductible on one specific person. We many times will take an option on that if we look at it and we say, okay, we know this person's either getting better or we know this person's condition has run its course and it's coming to the end. And we might feel good in saying, okay, yeah, he's having $44,000, but his coverage is ending July 1st or September 1st. And we don't see that going throughout the rest of the year. And if we can get reinsurance premium lowered by the additional liability we take, we're better to take the liability and pay it in premium, because there's always a possibility the person might not be covered. So we're just looking at it from a financial aspect of trying to buy the most coverage for the least dollars if it's an offset. Now, if we came to them and they said, yeah, we want $1 million on this person, we're going to give you $50,000 reduction in premium, you don't take that. Unless you can look at it and know the claim's over.
Question?
Just to be sure we understand, when you say, for instance, the premature baby lasered at 1 million, that means our reinsurance would not kick in until $1,001,001.
Correct.
We will have to take the first 1 million,
Correct.
and they will laser specific amounts for specific cases.
Yes,
And
sir.
so when you give us a laser amount, that is our exposure.
Yes, sir.
Okay. Any other questions?
But you can see we've had a couple of people with transplants, liver, kidney transplants. They're approved. They're waiting. Some of them have been waiting since December. It's going to go one of two ways. Either they're going to get a transplant or it's going to be too late. So we're waiting to see how that. The lymphoma approved for CAR T therapy. Y'all may remember we had a participant that went through a clinical trial 3 years ago, and had the CAR T therapy. They pull the T cells out of the patient's body. They engineer a drug and they put it back into them. There's pre-care, can be $400,000 or $500,000. The actual infusion is $375,000 to $475,000, and then there's post-care. So what some of them have looked at this at is an $800,000 claim. Now, he's been approved. It's ready to happen. It could happen any day now. Okay, so if it happens quick enough, we can get it paid before the end of the year, and the person's already met a number of dollars, a couple $100,000 towards their specific deductible, so it would limit the effect on the plan. And we're going to monitor that with Blue Cross and try to make sure we get as much paid as we can. We had a bone marrow transplant earlier this year. The patient seems to be doing very well. Got a person with cystic fibrosis that runs about $30,000 a month of drugs, and then we've got an ongoing brain cancer that the person's seems to be doing better, but it's a very harsh treatment, put it mildly. But those are ongoing things beyond what's already been paid. Some of it you can look at and say it's over. These are the ones they're saying are pretty much open. So the first thing I'm going to go through on the renewal is the administration. Last year we signed a 3-year deal with Blue Cross. They came out with a 7.37% increase to the admin fee. We got 2 offers from them after negotiating. We got them down to a 1.49% if we took a 1 year. We got them down to a 3.9% if we took a 3-year rate guarantee with Blue Cross. Y'all voted to accept the 3-year rate guarantee. So right now we're in the second year, or this will be the beginning of the second year on the same rate that we had last year. And it just goes through the math of how it was all set up. But the rate remains the same at $38.40. On reinsurance, I went out to 10 separate markets to try to get as best a proposal as we could, knowing that we had some ongoing medical claims. HM Life offered their renewal with a $450,000 laser on the current participant. They did the rest in increase to offset what the ongoing claims were. So they didn't give us any lasers, but we got a significant increase in premium. Excess Re offered a proposal, a higher reinsurance premium, and the lasers they came out with as of Friday totaled $2.7 million, including $1 million on the infant. So it really put them out of the marketplace on that. Symetra says decline. I'm sorry, they offered the most competitive bill. It's a $350,000 deductible with 1 laser. Blue Cross charges a fee to use an outside reinsurance carrier. It's $3. Symetra would give us $1 towards the fee. Blue Cross brought it down 50 cents this afternoon, so now we're at a $1.50 increase in the fee. We get $1 from Symetra if we go with them, And we get 50 cents off from the $3 from Blue Cross, but that happened at noon today. The only other carriers, all the other carriers declined to offer bids, some saying that their rates would be 80% of current, over 80% of current rates. So we've got 3 reinsurance bids.
That 50 cents offered today, what does that equate to in savings for us?
So we've got 4,000 people covered, so it's $2,000 a month, about $25,000. And the dollar that Symetra is going to pay towards it, again, you look at about $50,000. Mr. Bass, Mr. Cheatham's waving.
Sorry, first time. Mr. Cheatham.
No problem. The question I had, all these people that declined to offer a proposal, can you explain to me again why they would?
They felt like their rates were 80% over current or significantly over. I have to include significant lasers in order to be competitive, and they didn't think that they would 80. Or had multiple lasers that would have to wage.
On Symetra, I don't understand why it says decline to offer proposal and then.
It's a mistype.
Oh, okay.
I didn't read through it, corrected it. They did offer proposal. They have the most competitive proposal to stay at 350,000
And only one laser.
and only one laser. And their quote is the one that's firm through the 19th.
Okay. Yes, Mr. Bullard.
I'm sorry, could you explain a little better the charge, the Blue Cross charges $3, and what is the PEPM?
Per employee per month. Okay. So
And that's
the
in addition to their other,
admin fee. If we use a non-treated reinsurance carrier, they have reinsurance carriers that they're integrated with, that they send reports to routinely, that they have agreements that they will not investigate claims beyond eligibility, meaning that if Blue Cross pays the claim, they can't come back and reject it on us. If they pay it based on the report. The Symetra reinsurance contract mirrors our plan document, so it should not be an issue. But again, that integration, they charge a fee, and they're charging a fee of $3 for outside reinsurance.
if I'm following you correctly, we are are about to enter the second year of a 3-year contract whereby we pay $38.40 administrative fee
Yes, sir.
to Blue Cross Blue Shield. Then we would add initially $3 to that, but now you've negotiated it so instead of it being $3, it's $1.50, and Symetra is going to
Issue a
reimburse us
check back to,
$1.
yeah. Issue
So
check
a
back to the
net
plan.
cost to us of 50 cents.
$1.50.
Dollar.
It's $3.
Oh, excuse me.
Yeah.
I understood they had dropped it to $1.50.
No.
Okay. So we're now at $1.50. So basically, $40 a month per employee per month
Yes,
is what
sir.
we're going to pay to
Yes, sir.
Blue Cross Blue Shield.
Yes, sir.
Mr. Allman, could you clarify a point you made earlier? Last year, we agreed to a 3-year rate guarantee.
Yes, sir.
So why are we back this year talking about reinsurance again?
Because we're going to a reinsurance that's outside of their integrated model. So Blue Cross has 4 reinsurance carriers that they're integrated, they consider preferred reinsurance carriers, including HM Life, Excess Re, BCS, and Companion. Those, they don't charge a fee for using an outside reinsurer, and when we go through the contract, you can see it's got a fee or not a fee for outside reinsurance. So this year, we would be going to an outside reinsurance carrier, which is a separate fee other than the admin fee that was signed, based on the election to have an internal reinsurance carrier.
I'm not sure I understand if we, so we're wavering from the
From the terms of the agreement on the contract, it shows a fee for an inside reinsurance carrier or not an insurance. Last year, we had one that was an inside reinsurance carrier. So when they
Want to go outside?
call, because we couldn't get a competitive bid inside.
Okay.
But don't we have one more? We have one more left?
Because Symetra is $119,000 net lower than what HM Life is.
Right, on the 350. So what I'm going to go through now, if you get the staple part, I'll show you what the costs are. Sure.
Did you have a question, Ms. Brooks?
Well, I guess I just don't understand. We're in our second year, and we had a 3-year agreement.
Yes, ma'am.
So do we have another year left? I just
Again,
don't understand that.
and I've got the contract with me, and I'll show it to you specifically where it line items, what the charges are. And when you get down to an inside reinsurance charge, it says not applicable because there are an outside reinsurance fee, shows not applicable because we were using an internal reinsurance carrier. Now we would go to a non-inside reinsurance carrier, and there would be a fee associated with it.
I'm not sure everybody understands why we're going outside the network. That, all of that wasn't part of the 3-year agreement?
No, sir.
It looks like Ms. Bamberg
Mr.
has
County,
a question real quick.
the contract that we signed with Blue Cross last year was administration, which is one part of the health insurance. So the administrative is locked in for 3 years. This would be just the reinsurance portion. That may help explain it a little bit better. It's two separate contracts.
Okay. Mr. Bullard, you had a question?
Thank you, Mr. Chairman. Mr. Alman, if we have a proposal
Yes, sir.
from Excess Re, and that's where we were previously, I believe. Am I
Yes, sir.
correct? And they have come back with a proposal with a higher premium, but one laser.
No, now they've got 4 lasers. I'm sorry, I
Okay,
did not correct
okay.
that.
So in other words, what I'm looking at here is not valid.
Right. It's on the spreadsheet it is.
What impact or what offset would there be if we went with Excess Re and avoided the additional charge?
And that is an option. And again, we've got a quote
But I
from
mean,
them.
how much, let's talk dollars. They've got they're charging us, let's say, $1,000 here, and we're only paying $500 to Symetra.
So-
But then we've got to pay the additional monthly
Correct.
price, fee per participant. So how much offset do we get to the point that it would be advantageous to avoid that?
Can we
that
look at this
additional fee?
spreadsheet? Because it calculates it all for us. This
There's not-
spreadsheet here that you've got in front of you,
Okay, which one is it?
that's stapled together. This one here, oh, God, man, I'm sorry. The spreadsheet that's stapled together that's in front of you? Yes, yes. Because again, the admin fee from Blue Cross came back today. I was trying to push them to get a lower number on that additional reinsurance fee. So we've got 2019, which is the current. You've got HM Life, which still has the 3840 as the admin fee, which is an internal reinsurance carrier. You can see the admin fee stays the same at $2,022,000. Reinsurance premium, when we look at total annual stop loss, goes from $1,464,000 to $1,984,000. So that's an increase of $520,000. Still got the one laser, but it's $520,000. If I look at the next column, that's Symetra with the additional fee. So the admin goes from $2,022,258 to $2,095,014.60. The reinsurance premium is $1,768,731. So $220,000 less in reinsurance premium. So to go with Symetra and the one laser, it's $3,963,746 to stay on the same $350,000 specific with the same laser on the person.
Is that the additional 50% that you negotiated today, or? The numbers I'm looking at is 3987, you said 396.
Yeah, it's on this,
Something.
do you have this spreadsheet?
Yes, on
Okay.
that.
No, I'm sorry.
Yes, sir, that's why I put this addendum in there,
Okay.
because of that 50 cents off. I'm sorry. Again, they can take one person and put a higher deductible on that one person. Everybody else in the group is covered for the $350,000 individual specific deductible, and that one person on Symetra and HM Life is at $450,000. So we don't get a reinsurance dollar, as Mr. Bullitt pointed out, until $451,000. Okay. The last option is Excess Free Blue Cross Blue Shield. They put a total of 4 lasers. 2 people at $550,000, 1 person at $650,000, and 1 person at $1 million. The total laser liability winds up being like $2.7 million, or the additional liability $1,350,000 over the $350,000 specific. So we go out and we get outside bids to make sure that the inside bids are checked. If we need to use an access fee to access somebody outside and it makes financial sense, we would use one to protect the plan, to get the lowest reinsurance price available. Does that make sense?
Use someone outside of Blue Cross Blue Shield with this for reinsurance prior
We used
to?
ERC in probably 2003 for 2 years, and we paid a fee. Back then, it was only a fee of $1.50.
Negotiated now is $1.
You're right.
Okay. Ms. Smith, you had a question?
And all of these are for 1 year, or is the contract type show that one of them's offering, like is HM Life offering that for?
No, it's all 1 year,
Okay.
1 year term, September through August.
Okay.
So this is on a $350,000 deductible. We got options to look at a $400,000 and a $450,000 deductible. And those are on the next pages. So if we look at HM Life on a $400,000 deductible, because of the additional fee that Blue Cross would charge for Symetra, we'd be better off staying with HM Life on a $400,000 deductible. In order for it to be a break-even proposition, they would have to have 6 people get over $350,000 and get to $400,000 worth of claims, because the net savings is $311,000. So 50 times 6.22 people would get us to a break-even proposition. If we don't have 6 people, the plan saves money. If we have 6 people or more, it could cost the plan some money.
Last
Right
year?
now, we have 4.
And how many do we have last year?
I've got it back to 05, behind in the presentation, behind the end of the presentations. It's never been more than 4. The lasered individual does not count against us because he's at 450 regardless.
You would have to have 6 or more.
So we came down.
So if I understand, even with 17 over 175, 13 of those are less than 350 or 400?
Yes,
They're
yes,
between
sir.
the 175 and what's the potential that some of them could get into that category?
Well, again, it depends on how soon the claims happen and how far we push them through this year and not have them go into next year. When you're looking at the large claimants, you know, if none of the big ones we're talking about, transplants and things, get done this year and they wind up happening next year, then you could have more than 4 or 5.
Knowing what you know, how many do you anticipate that happening with?
Well, again, when you're looking at a self-funded plan, you're trying to buy the most cost-effective deductible if the plan can afford it. And on 4,000 people, $400,000 is not out of the realm of the correct financial aspect at 4,000 people, okay? If you were significantly less than that, you might stay at 300 or 350. But at 4,000 people, a $400,000 deductible with 6 times savings tells me that in the end, most years you would wind up to your advantage. Unfortunately, this year we're down to the renewal and 2 outside bids, one of which is completely uncompetitive. It would double the cost of the plan on reinsurance with the lasers in it.
Start going out for the bids.
April 1st.
And can you explain why you had to wait till that date?
Because, again, they don't want to buy something before they know what's coming up 9/1, and they won't secure it until we have at least 9 months of claims. So we couldn't secure it until we had May claims. Otherwise, they'd be very conservative and laser us as much as they'd like.
So I guess that answer that you just gave, so we can never plan a little bit better than cram in a 1-week meeting. Typically, we have to wait till those 9 months before we can start looking into renewal.
My philosophy is this, is to work it until it gets to the point where I don't think it's going to improve. And depending on the outcome of a few of these claims, it could get tremendously worse at this point than get better. We can wait until August 31st to secure it. It's just whatever the terms are at that point is going to be generated by the ongoing claims at that point.
My biggest issue, and I probably sound like a broken record because I think I've said this to you a few times, but here we are. This is a lot of information to digest and a lot of gamble one way or the other, and here we are. We're going to make a decision tonight, and then we're going to push it through Thursday without really time to think, ask questions. But it sounds like I guess we don't really have an option, but I'm a little bit frustrated that this kind of just jumped up on us, that we haven't had a meeting January, February, March talking about this and kind of forecasting it. But is that something we could have forecasted at that point, or is that something that just jumped into us in April when we decided to
The renewal is always September. So, I mean, I send reports to Nisha and to Superintendent Downing, not every month, but at least every other month, as far as where we are, what's going on with large claimants after review of it. And perhaps there should have been a meeting in April that says, hey, this is what we've got. We're going out to bid. Everybody's got to be aware of the potential issues we're going to have.
Part of my concern is it's just kind of like it's sprung on us. Like I didn't personally, I don't know about the other board members that are on this committee, but we didn't have a heads up at all as to how the claims were going or what was going on. And now we're in a, we got to pull the trigger now mode. But I'll move on from that thought process. If we went from the $350,000 deductible to the $400,000, does that mean we've now got to raise our employees, anything on our employees as far as their monthly premiums?
Right now, we're at 5.6 over last year, okay? Last year, I think the reserve was building at about 1.7, and I'll leave that to Nisha as telling what it was when she pulled the reserves out. The reserves are there to help in years y'all need an increase, okay? It's not there to develop anything. It's there to protect the plan as far as runoff claims. And that's the reason why they let you have up to 16% in there, is because that's what they project that you would need to pay all the claims if you shut the plan down tomorrow. And it will give you liquidity to get there. You can use that money to offset rates. Today we're at 5.6. There are some things you can change as far as benefits and deductibles and co-insurance. And whether or not you do any adjustments to employees or dependents, that's all at y'all's call as far as what y'all are willing to do, or even putting in a closed formulary on the prescription drug program, or retirees looking at Medicare options, Advantage options. Those are all options you can do to reduce or not have an increase. Again, the reinsurance and admin renewal every year is 9/1. It's the same program. Perhaps I've gotten too commonplace to say, okay, we start shopping in April and we should have had a meeting. I don't know if we could have had a meeting this April, but we should have at least had something that said, hey, this goes out to everybody on the insurance committee. These are the concerns I have as we review this.
Smith, then Ms. Brotherton, then Mr. Bamberg, then Mr. Downing.
Okay,
We're
so,
probably all gonna ask the same question.
so look at, on the last page of the extra handout, where you go under HM Life. So if we raised it to $450,000, that's $191,108. And then if you go to look at what we would have now for the $350,000, and you chose Symetra, which was the lowest on that, that's a $568,000 swing. So if we only have 4 cases right now, and that's our average, that's $400,000. So that we would be $168,000 ahead to do that. So you would still be at that 6-patient ratio.
Correct. You're very close to it. You're
Very close to the
5.92.
6-patient ratio to, if you went with the $400,000 plan, which is going to cost you, which would be about, I guess, a wash, $65,775.
But you have the additional plan.
But on this one, on the $450,000, if you went with HM Life, then you have the potential to be at about $200,000 less than what we spent this year. But it's a roll of the dice if you have 4 or 6 or whatever you have.
And it takes the additional liability of the laser off, that one laser. Since everybody's at 450,
Right.
you've got no impact from the 450 laser on the one person. Everybody's
I
covered
think
by the
that
same
one makes
reinsurance.
more sense at this point.
Okay, Ms. Brotherton?
I don't think I have a question, I think I have a statement. Insurance, I guess, is kind of rolling the dice, but we're about to give a rebate check, money back to all of our employees, insurance check back to them, and now we're sitting here talking about maybe raising their premiums. Well, that could be a possibility, you said.
Well, I think you have to look at the end of the year, and each year we have rates set actuarially because it protects the plan. It's the information we have to use for the W-2 reports to see what the cost actuarially would be for the plan. And those are set once all the reinsurance is in place, and they can look at claims. So we'd like to get through July to have a good set for next year as far as trend and everything else, so that at that point they can look at it and say, this is the number that we would project it on based on all of the stop loss that we received, all the rebates we received, and get a good firm number to protect the plan. And from there, you can look at it and say, do we need an adjustment? You know, if the rates today are generating 51 million and the plan's costing 50, maybe you don't need an adjustment. But it's based on that actuarial number to where we're not just picking a number out of the sky. For so many years, and when I first started doing the consulting work with the school board, Frank and I would look at the money and say, okay, do we need to go up? How was this? And then they came out and they said, each year we're going to pass along the increase. If the board gets an increase, the employees get an increase. And that was put into the board minutes, gosh, probably 2008 or 9. But it's in there as far as, I know, excuse me, Ms. Smith was on the board when it was put in there. It's just a matter of managing through it. Like I said, there are some things that are option that we need to look at. I've got some information I'm going to send to Adam on closed formularies. You know, if you look at every other fully insured plan out there, everybody else that has an insurance plan, they've done some kind of managed formulary to protect the plan from new expensive drugs that come out, or from routing against one manufacturer that's raising the fees on certain ones. And we've done a lot to protect the prescription drug plan over the years, but there may be more to do. You know, closing the formulary can save $1.5 million. I think it was 1.4 million this morning when I saw it. They said about 7% of prescription drug claims. But I've got to put it in a presentation that I can send you. You know, a great impact is what y'all charge for dependents and the volume of dependents that are covered. And, you know, and how many people y'all wind up covering today that are actually employees somewhere else, being a spouse that's covered here as opposed to being covered at their employer. So y'all have a lot of things that you can go through, and including some of the conversation we're going to have tonight as far as what to do with retirees and retirees with Medicare and what's available. Is it a good benefit or is it a bad benefit? How do you get there? It's just an option to discuss and go through. If I was going to change a benefit or change an out-of-pocket or change a premium, I would make that call in September, early October for it to be effective January 1. Deductibles change, out-of-pockets change. They all roll over January 1. Everything's on a calendar year basis. So when you're doing that, if you're going to change a deductible, change an out-of-pocket, change a copay, it gives people a new opportunity to see a new deductible. Likewise, you start talking about, you know, changing a plan here or changing a plan there. You have some options as far as how it renews and how it impacts people. If you change something September 1, you go up on a deductible, everybody has to meet that new deductible for the remaining part of the year. And then it starts over again January. So they kind of get hit twice.
I just have a couple points of clarification. Ms. Bamberg and I do get an increase or a report that shows the monthly increase may be up 3%, 7%, down 2%. That's really a fluctuating number. As far as the premiums are concerned, we've talked about this refund now for several months, and we've been very, very cautious moving forward. And the unknown landscape has been COVID-19. So we wanted to make sure before we made that move to refund those premiums that we felt that we were being cautious and that we were secure in making that decision. The legislative auditor is the one that reported that we needed to reduce the amount in that reserve, and so that we were abiding by that recommendation from the legislative auditor. Ms. Bamberg is on the line, and she may have a comment about some other discussions that we've had in the last several months as it relates to insurance. Ms. Bamberg?
Yes, sir. I did want to let y'all know I have kept a very close eye on the financials and on the financial, the balance and the reserves within the health insurance fund. And so we, like Mr. Downey said, we've very closely watched it. We've been careful with reviewing those amounts, and we're still showing a good balance and actually showing that the premiums are still covering the claims, even with the increase that we're seeing in the claims that are there. With the reinsurance that, you know, payments and things that we're able to get in, we're still able to cover the claims in that fund. So I don't foresee a need to raise the premiums at this point, but it is something that we watch very closely in that fund. And if it does look like that would be something we would have to consider, we would definitely let y'all know. But we were, like Mr. Downey said, we were very careful before we discussed the refund because we wanted to make sure we weren't going to give a refund and then increase premiums. So we are watching that very closely.
That's good, yes, thank you.
Mr. Bamberg?
All right, Nisha, I want to first thank you for your drop the mic statement right there, because that's what I wanted to hear from you for our employees. But Jason, is there, I guess all this is trying to figure out timing and deductibles and how many people are going to go over. Do you think there's any way holding off on this in any way could get more people involved now that they see, are they not bidding because they don't see what July is going to look like or June numbers are going to look like, or do you think this is just, we better get it while we can?
I think we're at the best point we're going to be at. Unless...
Are they in looking at our claims and saying, tell me about this person, tell me about this person? You know what I'm saying? So do they see through our lenses where we're going, man, we're really trying to get at why the claims are still low, but do they actually know that these claims are still going to have a tail with them as long, as
They
well?
know, we provide what's called a trigger report, a trigger diagnosis report. So it's an ICD-9 report that encompasses everything that they consider to be a trigger diagnosis, whether it's heart failure, diabetes, and they go through it with a fine-tooth comb. And they come up and they say, based on this, these are who we need to project. So then I go out and I get case management notes on everybody that's one of those people on the trigger diagnosis report. And we go through and we try to improve it. We try to figure out if the person's going to qualify for Medicare, or if the person's going to get covered somewhere else, or is this treatment coming to an end. So we go through all of that to project and to dissuade them from putting a laser on somebody if we can. When today my fear is that if we get past the 19th and a couple of things are either ongoing or happen, if the child's still in the hospital, if the liver transplants are scheduled and happen in the month of July or the month of August, it's all going to make it worse on the new plan year, because they can come in and just exclude somebody completely if they wanted to. Not necessarily the incumbent reinsurer, but everybody else bidding. And that's pretty much where they are. They said, look, we're not bidding because in order for us to be competitive, we're either going to need to be so high or put so many lasers on it that our bid is going to be invalidated just on the surface. Excess Re Blue Cross today called me and told me they thought they had a good offer, and why wasn't I giving it better consideration? And they're $1 million, $1.4 million over the most competitive quote.
Okay, thank you.
Mr. Bullard, you had a question?
Yes, and I'm glad Ms. Bamberg is still up. I'd like to hear Ms. Bamberg's guidance and opinion on these proposals, and the 350 versus 400 versus 450 reinsurance level. What guidance and recommendation would you have, Ms. Bamberg?
It is definitely something that we have to consider, and I am looking at the numbers now. I guess in my mind, I do like the idea of having that the limit lower as far as the reinsurance limit. I like having that at a lower number because then that's a safety net for us to make sure that we don't end up with larger claims. But at the same point,
could you
at the same
please-
time, we have to consider our claims over the last several years and how many have we ever had hit, 350, 400 and things like that.
Could you
So then it
define,
ultimately for me just gets down to the bottom line, which one do we project would be, the cheapest for us. And ultimately right now that would be the ones with the higher stop loss at this point. And so just strictly looking at the numbers I have now, which I think y'all have a little bit updated from what I have in the last email.
Behind the presentation, there's a listing of
One second, I don't think Mr. Bullard was through.
I think I follow now. I needed a little more defining information, but I believe it's covered.
Dunn.
Thank you, Ms. Bamberg.
Ms. Bamberg, can you hear me?
She's
Okay.
muted.
She said yes, sir.
You have, if we decide that we want to act Thursday, you have essentially 3 days where you can formulate your recommendation about which one of those thresholds that you would be comfortable with, if that's something that
Yes, sir.
the committee would consider, allowing her to have a couple more days to look at those numbers and see which one she'd be more comfortable with. Just a
Yes,
thought.
sir. It has been a moving target. I have not, unfortunately, had a chance to sit down and discuss it a little more with Jason to see all the different factors. Right now, all I'm really going by is the lowest total annual fixed cost and, the total annual cost with the laser included. And so that's all I can go by unless there's other factors there. I would like to go over it with Jason and just make sure we've considered all options and be able to have a firm recommendation at that point.
So what I'm understanding is we are looking at giving Ms. Bamberg a few more days to analyze the numbers with Mr. Allman and then come back with a recommendation to this committee and this board as to what you would recommend on how to proceed.
If that's the only sticking point, if we feel good about everything else, I'm just suggesting that as an option. If the threshold is the only thing that we have concern with, then if we could allow her a few more days to look at that and make a determination what she felt like is the safest option for us. That's,
Mr. Allman, you had?
Behind the presentation in the booklet, there's a listing of every deductible, every premium we've paid, and every large claimant that's met the specific deductible. So you can see all the way back to 2005 how many has ever broken a $300,000 number or a $500,000 number. It's behind the presentation, behind the numbers. It should be right after the proposals. Looks like this. Yes, right there, Mr. Bullard. So it goes all the way back to 2005. And you can see the variations when you start talking about it, and you can see, you know, in 2012, how many people breached the 200 and why we moved it to a 300 and why we moved it to a 350, and trying to reduce the fixed costs, because again, you're trying not to pay more money in fixed costs than you need to. The lower amount of fixed costs you pay, the better off the plan has to survive. One other thing I'm going to say is that when we look at this and we look at even staying with the $350,000 deductible and taking a $520,000 increase to fixed cost, it winds up being a 0.006 of a $50 million number. The reinsurance cost in itself is not going to cause a rate for somebody to have to go up on an employee. So it's really a function of claims. And unfortunately this year we've had a spike in large claims. And that's what's driven both the cost up and reinsurance costs in the future of going up. And if that corrects itself, it'll come back down. So you've just got multiple factors pushing on it. But when you look at even, like I said, $520,000, it winds up being a small number of the total cost of the plan. So in the end, my belief is you buy the best specific deductible that makes financial, economical sense to you, whether it's 400 or 450. And the reason you need a specific deductible is because now everything's unlimited. Back in 95, 2000, 2005, there was a $1 million lifetime maximum. Nobody ever got to it. Affordable Care Act happened in 2010, and you can see the complete deviation from claims prior to 2010 on that sheet, and then all of a sudden you see $1 million a year claim popping up. Several $400,000 claims popping up. So the Affordable Care Act had more impact on the large claim than anything else.
One, what is your recommendation to this committee and the board as far as the numbers that you have looked at? And two, if we do make a decision on Thursday to execute that before the deadline of the 19th, is there a date that locks us into?
So the 19th
do we have
applies
the ability?
to...
Oh, I'm sorry, were you speaking?
Go ahead.
Okay. Do we then have the ability to change that at a later date if we take some of the cost-saving measures that we're going to discuss this evening and some other things that you mentioned with the formulary and that type of thing?
Okay. So the first thing, the 19th is the Symetra quote on 350. So if you're not bound to the 350,000, if you're going to the 400 or 450 with HM, I've got that firm until the 26th. Okay, so we have until the 26th to actually elect their proposal, and nothing's going to change. My recommendation is to take the highest deductible the board's comfortable with. Because of not wanting to inundate or put too much liability on it, I would say the 400, but the 450 is completely feasible and advisable. But it's a matter of how much are y'all willing to bite off and put against the fund? Because you've got to remember, Now for every person that goes over 350 and gets to 450, y'all are picking up another $100,000 of liability. It may be one, it may be none, it may be 10. Historically, it's nowhere near that number.
Confused. I heard you say 350, 400, 450, but I didn't hear you say what your recommendation would be. Would it be the 400, the 450? And then if we did the 400, it buys us an additional week in the ability to make that decision? Is that right?
My recommendation would be the 400 or the 450, whichever the board is most comfortable with, okay? The 400 is advisable. The 450 is definitely within the realm of acceptance.
6th for that deadline.
Yes, sir.
Does that give you enough time to bring in front of this committee and this board some of the other options that you mentioned as far as a cost-saving measure?
So when you're talking about benefit changes, when you're at a 450 or 300 or $350,000 deductible, inside benefit changes play a little effect on that reinsurance cost, no effect. Because the reinsurer is not taking any ownership until somebody gets over $350,000 or $400,000. So changing a deductible, changing it out of pocket, putting a formulary in, a closed formulary in, is not going to adjust the reinsurance cost. It's going to adjust your claims cost, which you actually pay out of pocket. Because somebody getting to a $350,000 claim, it's not going to matter if you put a $5,000 deductible on it. It's not going to adjust that claim greatly. So changing those benefits. Now, if you were to say, okay, we like what we hear on this Medicare Advantage plan, and we're going to move 1,200 people off the plan. Well, the contract with Blue Cross gives them the leeway of adjusting an admin fee if we do over a 10% reduction in enrollment. The reinsurance carriers get to renegotiate everything if you pull out over 10% of the people. Okay, because that's not what they're making their bid offer on. They're making a bid offer on people that you have today. So my advice would be that to secure it, because once we elect to have it, it stops underwriting. Okay, if we tell HM Life before the 26th that we're renewing with them and we're taking a 400 or 400, their underwriter stops. Doesn't do anything else unless we come in and change the terms. So if we come in August and say, okay, what's your cost if we take 1,200 people off? Or in July, and we say, what's your cost if we take all these retirees with Medicare off? Well, they can change the terms, but we don't have to buy it if they change the terms. And we can stay on what we have.
We just can't take those people off.
We can take them off, but they have the right to adjust their offer.
But I mean, and then if we decide to stay where we are, we can't take them off.
Right.
Problem with that, I guess, is my question. So we make this decision, and we're basically telling them we're going to renew it, whatever that is. We then can keep that, or we can go back to them and say we would like numbers based on us removing however many people it is.
So I'm going to tell them we're renewing based on this. We're doing a study. We need to see what happens if we pull all the retirees out. How would that adjust your number?
Okay.
I've asked Blue Cross for their number if we pull the people out. Because again, I've got the contract, I read through it this afternoon, or the application from last year with a 3-year rate guarantee. It said if enrollment changes greater than 10%, they can change the terms.
Okay. And in your experience, if we were to take one of those measures, does that premium normally improve greatly? Is it much worse? How does that normally?
Well, they'll look at the risk. Okay, and if they look at the risk and say, we've got $1.5 million worth of claims we're projecting out there, they're going to want 1.5, north of 1.5 premium, whether it's 2,800 people or whether it's 4,000 people.
So it would matter which of those we removed for that?
Yeah.
Okay, so just so I understand you correctly, if we gave Miss Bamberg until Thursday to review the numbers on 350, if her recommendation would be for us to go to 400 or 450, that deadline would not be until the 26th of June.
Correct.
Okay. Mr. Cheatham?
I'm not trying to be funny here, but it's probably going to come out as funny. So we started on April 1st, with the bids, and as of like 2 hours ago, somebody was lowering a 50 cents. So maybe we could call them and tell them we've got 3 days to make a decision, and if Blue Cross was wanting to get right, maybe, or if the other company was wanting to get right. So it sounds like this is a last-minute game. I'm not going to compare it to the stock market, but the last minute, everybody's trying to get right at the last minute, and then you got to jump on it.
There's a couple of things that come into the mix. We shop reinsurance and we try not to bid one against the other, because what happens generally is somebody saves you a bunch of money and they don't get the business because you wind up beating somebody else down with their number. And somebody takes it, and the only reason you got that number is because the other guy came in low first. So we try to be as judicious with that as we can. The reduction in the fee today was because I thought the $3 fee was too much to go with an outside reinsurance carrier. If it's $3 on 4,000 people, it's $144,000 a year to have outside service. I was trying to get them down to a $2 fee, and that way $1 off from the reinsurance carrier. We've got something that the reinsurance carrier has given us a good bid. We're buying it because it's an affordable option. We can definitely take the numbers and play one against the other.
Concern with this is, it's already rumored or out there that, we're going to be expecting a $6 to $8 million shortfall with COVID and everything that's been going on. So we've got to find places to make that money up, not places to spend more. Yeah. And again, I don't know if this is a position where we can do that, but that is something, as we're talking about the possibility of spending an extra, 400 something thousand or trying to save money. We're going to have to look everywhere to do that. And I also think we're going to have the same problem next year. And I think at some point we're probably going to have to not just shop reinsurance, but shop all of our insurance to make sure that the millions of dollars we're going to lose in 2020 and possibly in 2021, that everybody's doing their part to try to save. We're going to obviously have that in every part of our budget, but I think in this part of our budget, that's something we're going to have to do as well. But it wouldn't hurt to use, if we're going to use the next 3 days for Nisha to look at numbers, for maybe somebody else to look at sharpening their pencils, to try to help us as well, would be my comment on that.
Real quick, if we were to table this and have another insurance committee meeting at 5 on Thursday before our normal board meeting that is scheduled, do we have any issues or anything that would not allow us to do that?
Since this is just discussion item or action, couldn't we just discuss it at the board meeting on Thursday? Would we have to have
does this have to come out of committee, I guess is my question, in order?
I don't think it does either. I don't see our attorney, but I don't think we would have to actually have, we could if you wanted to, but I think we could bring this item on the agenda and discuss it and vote on it at that time instead of having two separate meetings.
Then I would entertain a motion to table this until Thursday's meeting, pending Ms. Bamberg coming back with some information.
And I don't think we need to, there's not a motion, so just a discussion item. I think we can just give the staff to the information to bring back to us to Thursday and have it on Thursday's agenda.
Okay. All right, Mr. Allman, thank you for your expertise. We'll hear from you again, I would imagine, on Thursday, you and Ms. Bamberg. Next item on the agenda is a discussion/action, information on Medicare Advantage presented by Michael Guyton, CHR Partnership.
Good evening. I just wanted to follow up. I had a reminder on my calendar to follow up with the school board. We were talking about tax cuts, and and our tax revenues being down right now. And something we've done for 3 of our other groups here locally, the Bossier Parish Sheriff's Office, the City of Bossier, and the Caddo Parish Sheriff's Office, is move their Medicare population over to a group Medicare Advantage plan. And by doing that, we've, one, been able to save them, those 3 groups combined in 1 year, saved over $1 million. And you're thinking, okay, well, what was the benefit change? There was no benefit change. If anything, these retirees actually had the same benefit, if not better, because now they have something called silver sneakers. They have Meals on Wheels. They have other things that's in addition to that they're not getting today, okay? So these plans are plans that are actually, they can't have a lesser of a benefit than Medicare has today. It's governed by the federal government, so the CMS has those guidelines. But, as a taxpayer in Bossier Parish, it was something that I think that we need to go out to bid on, gather the information. I'm not telling you you're going to save $1 million. I'm not going to tell you you're going to save $5. But it's something that I think we need to do our due diligence and look at for information purposes only and see. Now, Mr. Alleman talked about, rebates and things like that we get, and all of that will be factored into it. Because you have to look at, like you were saying, the whole picture. You can't just look at one piece of it and say, okay, you're saving here, but we're taking away this rebate or we're taking away this. We have to look at what Blue Cross is going to do on the admin fees as well. But all of that will be taken into consideration. And then you come back to the table and you look at it and you say, okay, is this something we need to look into further?
Question on specifically what's being asked. Yes, sir, Mr. Bullard.
I have had a couple of people, just in passing, comment about how well pleased they are. They've been transferred to this plan, and they were very complimentary. But I'm gonna be honest with you, I don't know enough to make any kind of a decision. Do you not have any material that will explain to us, that you can put in our hands and we can read and gain a full appreciation and understanding of what you're proposing?
Well, it's hard to do that without information to go out to bid. So we have to have the information, and what we would do
But
is
the plan itself, I'm sure.
the plan would actually, what we would do, we would take your current plan and we would mirror that plan. So the benefits would be exactly the same, if not better. If there were areas that they couldn't improve on, there were less, they would try to improve on.
I'm sorry, I'm still at a loss as to exactly what you're proposing. You're saying you're going to give us something equal or better at less cost.
I'm not guaranteeing it. I'm saying it's something we need to look at, because the 3 other municipalities we've actually presented this to, we took their information, we went out to bid, and we looked at everything as a whole and said it saved them money, it made sense, and the retirees actually were not affected by this. There's a lot of retirees, like you just said, that we go to some of these retiree meetings and they come up to us and thank us for this benefit.
I've heard positive feedback from a couple of people.
Right.
And maybe they were the exception, but I guess maybe I'm a little slow. But I want to have a little better appreciation and grasp of what the proposal is. And that's my only concern.
Mr. Dean?
Just a comment, I retired from Texas, and I'm on the plan. And it's actually, when I had the opportunity to get insurance here, it's better than what we all, and I get the silver sneakers, the physical, once a year, and I'm not had any problem on any doctors that I've used. For me, the plan has worked quite well.
The group Medicare Advantage plans are actually really good plans. Now, a lot of people, even including doctors, that's the biggest hangup, is you get them confused with the individual market, these plans that people are getting for free. So they operate a little bit differently.
Quick, Mr. Guyton, to get what Mr. Bullard is asking for, which is plan specifics, you would simply need information from us that we can
Correct.
provide you to get that information that Mr. Bullard's asking for.
Correct.
Okay, so, anybody, yes, sir, Mr. Downey? Oh, I'll come right back to you. Mr. Downey had a question.
We met with Mr. Guyton last year and discussed this, Mr. Rowland and myself, and I believe Mr. Cheatham was present. Were you present as well?
When I was president.
Well, one of the questions I have is, with these three municipalities you're talking about, they don't have the same guidelines with the Office of Group Benefits that we do as a school board. And so, if I understand it correctly, I think Ms. Bamberg is on this call as well, we can't force anybody to change plans. They would have to volunteer to do that. Is that correct, Ms. Bamberg?
Yes, sir, that is the understanding. Blue Cross, OGB, which is the guideline that we would have to follow, we can't offer less than what they offer. They offer it as an option, and so we would have to offer it as an option. And so if we do look at getting a quote for the what they could potentially get for us, then we would have to consider that as well, that we can't require our Medicare retirees to follow this plan.
The sheriff's office has this same type of statute where they cannot offer a lesser plan than they're offering to their active population. They have attorneys on staff, and what they did is they got their attorneys on staff to look at it and look at the statutes to make sure that they were in compliance as well.
Mr. Cheatham?
Yeah, and I again, we would have to have attorneys look into this, but before we even got to that point, I think we need to get information on, and I think they need information from us. And we met a year ago, and a lot of times we hear, well, people don't want change, they don't want this. And again, I'll go back to the fact that we're about to face a $6 to $8 million shortfall, and if we can save some money somewhere, are we doing the taxpayers justice if we don't even look into it? Not saying we need to change to it. Who knows? It might cost more. It might not have. But to shoot holes in it before, and I think I allowed that to happen last year. I allowed holes to get shot in it before we even got the information on it. And I think we would need to get information from them, get them together with Jason, get the information, bring it back to us, speak to our attorneys. If that's the only plan that we offer, and it's, again, the Office of Group Benefits is who the Sheriff's Department, I believe, uses. Most of your state agencies use the Office of Group Benefits. I think it's something that we owe ourselves and we owe the taxpayers, that we're looking to try to save money. And if it doesn't work, then, we just wasted a little bit of their time and our time listening to it.
Yes, sir. You're next, Ms. Bullard, then Mr. Backhouse.
I've heard complimentary feedback, and I've got questions. I think several of us do, but we cannot get specific answers to specific questions unless we provide some information that would allow them to seek a proposal. And so if I'm understanding this correctly, then I would not be opposed to providing whatever basic information they need in order to come back with a specific proposal.
So is that a motion to?
I will make that a motion, and I want to make it real clear, because we may have some retirees joining us via the internet tonight. This is not going to in any way impact their plan. It may well evolve into an option. And if I believe what I've heard and what Mr. Dean has said, it's a preferred option because of some of the additional benefits it can provide. But yes, I will make that motion.
All right, so I have a motion from Mr. Bullard to give Mr. Guyton and his team the information they need to bring back specifics. I have a second from Mr. Cheatham, and I have a comment from Mr. Backhouse or a question.
I have a question. Are you saying that this takes the place of regular Medicare? And so Medicare Advantage?
You still have to pay Medicare, so that's where a lot of confusion comes in. So it takes the place, the federal government gives them a subsidy to take over the Medicare population, is what they do. And that subsidy is different depending on if people are sick and depending on the part of country you're in. But you still have to pay your Part B premiums. You still have Medicare Part A. What it does, though, right now you're going to the doctor and you're giving them your Blue Cross card, you're giving them your Medicare card. They're coordinating benefits. There's all kind of stuff that comes up with that, and I'm sure many of you in this room have had problems with that. This alleviates that. You put the Medicare card in your drawer at home, and then you give them your one card, whether it's Blue Cross, whether it's Aetna, United Healthcare, you give them that card. There's no more coordination of benefits. You still have Medicare, though.
The group that you're talking about, and I have to give my Medicare card first, and then I give my Aetna card second.
You shouldn't be doing that because there's no reason for that.
Humana Medicare, and I just give them the one.
Yeah, there's no reason to ever give them because once you're on a group Medicare plan, there's no coordination of benefits. You can have other outside coverages. There's no coordination of benefits. That's the plan that you have.
So one additional question. I have a motion and a second to get you the information you need to bring this committee back, the information that we need. What would be the time frame that you would need in order to put together what Mr. Bullard is asking for, the information, and then bring us back specifics? How long does that take to compile and then get that information back to us?
I would say a good 2 weeks, a good, 10 working days in order, and that depends on too, that's just when we send it out to bid to give them all, time to do it. That's also going to depend on when we can get the information.
Okay. Well, I feel confident that Ms. Bamberg and everybody will get you what you need. Yes, sir.
I just got word from her. She'd be glad to work with Mr. Guyton and get him the information he needs.
Okay. Any other questions? Okay.
I wrote down a couple of notes. I don't know if we can just do it outside the motion or not, but Jason, a lot of this will have to do with finding out about the admin fees and reinsurance, what that would look like when we put all the numbers into both sides of the equation, and also if there's any benefit change whatsoever to our retirees, because that non-starter, if we're going to have any change to our retirees, we're not going to open that up, I don't think. So I'd like to, one, like other people have said, make sure there's no benefit change, any at all. They still have their same doctor choice. And then we'd also need to have part of that, say, for our attorneys to look in on that, whatever the law is that tells us whether forcing and whatever all that is, to make sure that we're within compliance of the law.
Okay. Superintendent Downey, can you get that information to our attorneys to begin review so we can look at this when they do bring it back to us also? Okay. All right. Any other questions? All right. I have a motion and a second. Those on the insurance committee, all in favor? We don't have our clickers, so raise of hands. Okay, that is passed unanimous to get Mr. Guyton and his team what they need, the information to bring back to this committee at a future date. No other business to come before the board.
Thank you.
Entertain a motion to adjourn. So moved.
Second.
Second, all in favor? Aye.